this is the overview of my presentation. I'll be going through these aspects. Known as the Pearl of Indian Ocean, Sri Lanka is a beautiful country with a lot of diversity in scenic-wise, the demographic-wise, as well as population-wise. We have about 20 million people in our country. I know it's very small compared to your country. But again, we have about 17,000 medical practitioners to serve this population. So roughly about one doctor for about 1,200 people in the country. According to the studies done or statistics, about 110 million first contact consultations take place for these 20 million people in the country. Out of that, about 50 million happens in the government sector, government first contact departments, 20 million clinic visits, and about 40 million by full-time private practitioners. But unfortunately, there's no structured training program for vast majority. The sad thing is actually at the moment we have about 1,200 people who have qualified in diploma in family medicine. But most of these people are practicing either in ICUs or tertiary care units. So the government has actually not made use of this training that they have got in family medicine. So if I move on to the medical teaching, the university system in Sri Lanka, this is a map and the population density, and you can say most of the medical schools are located in the mostly populated suburbs of Colombo and suburb areas. We have 9 government medical schools, and so far, most of the medical training is run by the government. And out of these 9 medical schools, we were the first to start that is my university is the first one to start family medicine teaching program in the country. We started as community and family medicine department. Somebody was asking in the previous session whether we could start. Yes, you could. And later only we became an independent department. So we became independent department of family medicine in 2003. In other 4 universities, there are family medical units, no departments, but they have 1 or 2 lecturers in the department who conduct the teaching and training programs. But the other, that is 3 other universities that I have mentioned, they have only few lectures into first contact care and few GP sessions, unfortunately. So since ours is the most matured program out of the lot, I will take you through what we do as undergraduate teaching and postgraduate teaching at the Postgraduate Institute of Medicine in Colombo. So this is actually my department and this is our clinic. So as to what we teach our students about coping with undifferentiated illness and identifying serious illness from self-limiting and minor similar presentations. I think this is very important aspect that we need to inculcate in our trainees, because we see a lot of misses happening at primary care level. So as gatekeepers of the community or from the community up to the tertiary secondary care, it's very important that they know to recognize the points of referral. And then accurate management in the context of other conditions the people are having. Because again, whole person can managing not compartmentalized, like this is not gynae, this is not pediatrics, this is not surgery, but it's a person with the problem, and most of the things we can actually manage at primary care level as a GP. So we try to give them that idea. The impact of disease on the lives and lifestyle and the life of these people who are coming to us, because it's ambulatory care, not like a person who is an inpatient. So we need to train our people to handle patients who are coming into treatment but going out and getting involved with their day-to-day chores in the community. Then communication and consultation skills, we put major emphasis on that, and then we sort of get them to talk with patients, not only with the patient but with the family, and also we teach them how to communicate with secondary tertiary care clinicians, mainly by referral, how to write referral, how to communicate, things like that. Then we teach them the principles of family medicine like continuity, coordination, health promotion, disease prevention. And again, this is, I think, something unique that we are trying to teach them, setting up the practice in a community. Why? Because after MBBS, according to my country, I think it's the same in India, anybody can have a general practice clinic and see patients. So we try to give them some input as to, okay, if you want to start, what are the minimum requirements? How to have a medical record system? What are the minimum facilities that you should have in your practice? What are the essential drugs that you should keep? Things like that. At least a basic idea as to what they need to start a practice. Then where we teach is our main teaching takes place in the final year, 1 month professorial appointment, and this is again something I would like to emphasize. If you want to start family medicine teaching for undergrads, we should aim to go for final year. It's not my feeling, but now most of our GP trainers, they get students from other medical schools as well, which are mostly coming from 3rd and 4th year. And according to them also, they cannot really grab the conceptual things that are in family medicine, and they cannot really put everything together and manage a patient with complicated current acute problem and maybe underlying few problems. So that is very important. Like when you want to train somebody, those those children also should be able to understand what we are talking about, and they should be able to grasp, otherwise it's of no use. So we have one month final year appointment. Then 2 weeks, we send them to a preliminary care unit. This is something we have in hospitals. It's like something similar to a day center where they manage all the acute emergencies coming in, and then they decide whether to send home or to admit to further management to the hospital. So here, actually, we want them to learn about managing emergencies coming into first contact level. So as a GP, the things that they have to manage on their own. Then we have 10 days in the community. So I'll come to that in a while. And then we have 30 didactic lectures to teach mainly the concepts and things. So we have a model practice center with about 3,500 registered families, and we send the students to community GPs. Then we send them to hospital primary care units where we have now consultant family physicians are manning these hospitals. So the hospitals are mainly sort of community based, and they have people coming around the village, and the family physician is there to look after these people. So our students get a very good deal of training from them, and they get to know about the first contact care in a planned primary care setup in the hospital or the government sector. Then we send them to the outpatient departments of teaching hospital where the practices are very busy. So it's sort of mainly for comparison purposes. So they themselves realize in a big hospital outpatient clinic, you cannot really provide quality first contact care. The patient to doctor contact time is only few minutes, maybe 1-2 minutes. So you cannot provide proper care. Then we send them to hospice and home visits. Again, as primary care physicians, we have to deal with aging population, palliative care, things like that. So they get some input from that. Then elderly visits in the community. With the, again, aging population, we need to know the needs of the elderly. Preliminary care unit, I said it before. Then rural setting during community-based medical learning appointment where they reside in a rural community for 10 days. And they visit primary care hospitals in that area to see what problems they get, how they manage with very resource poor settings, and then they visit the community to talk with the community people, leaders, people residing in the community about their beliefs, practices, and their utilization of healthcare. Then we have small group discussions on prescribing, referral writing, and then they sit in with us when we do consultations to follow the consultations, to see the doctor-patient relationship, how we apply the principles of primary medicine in practice. Then they come to the clinic with they sort of write notes of patients and they discuss with us. Then we have hands-on skills training. They do consultations and observations, something similar to mini-sex that's happening in the Western world, where they do a consultation, we mark then and there, then we give them feedback on what they have done. So we think this is very important because this is the cornerstone of primary care provision. Then we have, they go for interactive sessions at villages for elderly visits as well as the community-based attachment, and then they maintain a student portfolio. So this portfolio actually they maintain during their second and third year of medical school. When they visit secondary care hospitals, we want them to write about the people that they see and what happened before they came to the hospital, from the point of starting of the illness, what happened really, and then the initial management at hospital, because during 1 month we cannot cover the entire spectrum of diseases in family medicine. Then we assess, we have a portfolio viva, community-based appointment, and after the appointment, a viva and a reflective log. Then they have a written paper with MCQs and SCQs, and most importantly, 8 station OSCE, 10 minutes each, a very comprehensive OSCE to assess their skills in primary care consultations. So when they qualify MBBS post-intern period, if they want, they can take the path to go up to be an expert or specialist in family medicine with the diploma and MD. Now, Postgraduate Institute of Medicine is the only recognized institute in Sri Lanka to provide postgraduate qualifications for doctors at the moment. So, they started the first diploma in family medicine course way back in 1979. So it has a very good history, and now it has evolved to a great extent, the course and the exam both. Then MD in family medicine, initially we have started by thesis in 1980 and then by clinical training in 2000. Then for a brief period of time, I think our PGIM came with their diploma in family medicine and MD to India. But now it's not happening, but I know Dr. Alul Raj is trying to get it back again. Then the College of General Practitioners of Sri Lanka is offering a course, and it is accredited by Sri Lanka Medical Council as added qualification. Again, MRCGP International is another examination we encourage our people to take. This is again accredited qualification by Sri Lanka Medical Council as an added qualification. So if I am to take you through briefly about our diploma and the MD programs, now diploma is 12 months face-to-face, and it has 3 main components, that is taught program, the lectures, clinical and practical training program, and skills training program. Actually, we had a diploma of in family medicine online program, but for certain practical issues, we have stopped it for the time being, but we probably will be starting it soon. So the online course was 2 years, and then it had some modules, discussion forums, clinical training, skills training, different aspects. Then this is the credit hour distribution in the diploma course, and the assessment of diploma again is they maintain a portfolio, so the portfolio viva, the MCQ, SCQ, and the structured OSCE. Then MD, to do the MD, diploma is a prerequisite at the moment. So people who qualified with diploma sit a selection exam with MCQ and XCQs, and then they take up the clinical training program. The initial part of the MD program, that is pre-MD time, we have mainly two components, that is primary care training and training in other specialties. For the primary care training, we have 8 months in university family practice centers, that is in my university and at Kalani University, and then training with general practitioners approved by the Board of Study for 8 months, so that they go to community GPs and see how the care is happening there. Then they go to hospitals, specialist clinics, approved by the Board of Study again. They do rotations in like major disciplines like medicine, surgery, pediatrics, gynae, as well as small, subspecialties like cardiology, respiratory medicine, again public health. So they get inputs from a broad spectrum. Then they need to do a dissertation, that's a research component of the MD, where they submit a proposal pertaining to primary care, and then they need to give a report of 6,000 to 8,000 words. And then they need to maintain a portfolio where they have case studies, procedural skills, most importantly the reflective logs about their training, what they have seen, the incidents, and then they go on to write critical appraisal about few articles. They are supposed to do a clinical audit. So it's a fairly comprehensive portfolio that they have to maintain. Then for the exam, they have to complete the portfolio and then submit and complete the viva, and then dissertation and defend their dissertation with a viva as prerequisites for the MD examination. Examination of MD exam proper is again MCQ, SCQ, and they have 10 OSCE stations, 10 minutes each, again a well-structured OSCE. Then that does not stop their training. After they get through the MD examination, they have to have 12 months of supervised training locally and 12 months in an overseas place to make them a board certified specialist in family. So it's actually, even though the initial training is 3 years, it's actually 5 years training that you have to undergo to become a specialist in family medicine. Only the MD program, and added, if we add the 1 year's diploma, which is a prerequisite, it's altogether 6 years of training to become a specialist in family. So that's a fairly comprehensive training that they get. This is the credit hour distribution again. Then we still have the MD by thesis, where they submit the
Just
proposal.
a couple of minutes.
Yeah, 2 slides. And then they do a research study for 3 years, submit the thesis, and they defend the viva. And then after that, they also have to do the same sort of clinical training, 2 years, 1 year local, 1 year overseas, with portfolio. They have to maintain a portfolio at this stage because they haven't done it before, and then they have to face the OSCE to complete the training. So what is the future? 1 month finally appointment for all the medical doctors or medical schools. So this actually, we have had several meetings with medical schools, Ministry of Health, and we have submitted a proposal to the University Grants Commission of Sri Lanka. So it's under the pipeline. So actually, just a few minutes ago, I requested the WONCA and maybe the WHO, if possible, to support this to go forward. Then standalone MD program, that is without the diploma as a prerequisite. We are really behind the minister now. We had several meetings in getting the GP register done, and with that we want to mandate some sort of a training for all doctors who go to provide primary care. We know we cannot say actually, okay, you have a qualification and then come to primary care, because government cannot pay the salaries. So what we want to do is, when you register, maybe within 5 years of registering, you need to have some qualification, maybe diploma, maybe MCGP, maybe MRCGP, something, if you want to continue as a general practitioner. I think that is maybe too optimistic, but that is our vision for the future. So with that, I will end my talk, and this is an open invitation for everybody to come and see the beautiful Sri Lanka and to participate in WONCA South Asia Conference in February in Colombo, Sri Lanka. Thank you.